afternoon. I'd like to welcome you to the latest in our series of women's rights in healthcare seminars. I'm Sanja Strykevich, a partner at Leigh's medical negligence team. The topic of today's discussion is menopause and perineal injury. Our learned panel will be discussing how we increase education and awareness amongst women about the consequences of childbirth. We want to empower them to ask questions about their options and the treatments available to them, and to seek help if they need it without the fear of stigma. For those of you who are on social media, please don't forget to use the hashtag WRH2020. Now, it would usually be my role to introduce our speakers, but we have a very special guest who has kindly recorded a message of support. So I'll leave that job to her. Now over to you, Baroness Julia Cumberledge.
Well, I'd like to welcome everyone to this webinar organised by the MASIC Foundation. Supporters will know MASIC is a charity very active supporting women who suffer injuries after childbirth, injuries which impact on sufferers' daily lives and the quality of their lives. It is totally miserable not to have control over functions which the rest of us take for granted. Bowels and bladders are not body parts we want to talk about. Those areas are taboo for polite conversation. Something to hide, which leads to isolation, which impacts not only on those who suffer, but impacts on family, friends, and social life. The menopause can be a time when these problems first surface. Seeking help is doubly difficult. With the COVID-19 pandemic and face-to-face meetings are something of a rarity. Not all of us are super wizards when IT technology and face-to-face meetings are so valuable. So this webinar is welcomed to hear and get advice, and it gives me great pleasure to introduce the speakers. There's nothing so strong, I believe, as personal testimony. So our first speaker is a mother who suffered from a traumatic birth. She will explain how she has coped and what advice she can give to others in a similar situation. She's then followed by three professionals to provide advice. Dr. Louise Newson, who is a national expert in menopause advice. Dr. Radhika Vohra, who works in general practice and who has an understanding of the ethnic issues which we need to address. And finally, Dr. Ranee Thakar, who is a gynaecologist and a vice president of the Royal College of Obstetricians and Gynaecologists. She's involved in a national enterprise to prevent these injuries, and she will also give her experience of advising women with these problems. So now it's back to you and the webinar.
Thank you. That's a really very moving, actually, listening to such an inspirational woman introducing us all. So it's a great privilege to be here today chairing the meeting. And for some of you who don't know, actually, I'm just going to spend a couple of seconds really talking about the menopause, because that's a taboo in itself. This is a natural process that every woman on the planet will go through. Some with very few symptoms, many with a lot of symptoms, and several with symptoms that have a very negative impact on the quality of their life. But all menopausal women have low hormone levels that will live in our bodies or last in our bodies forever unless they're addressed. And the tissues respond to estrogen all over our bodies, and especially in the perineal area. And the perineum is an area that a lot of men and women actually don't realise they have in their bodies. And a lot of people don't realise until there's a problem with it. We take so much of our bodies for granted until there's a problem. So I'm hoping the next hour and a half you will really be able to learn a lot and think about issues that maybe you've never thought about before. So it gives me great pleasure to introduce our first speaker, Jo, who's going to tell us about her own experience. So thanks, Jo. If you could just tell us about your experiences with the childbirth, please.
So hi everyone, I'm Jo. I'm a personal trainer and I love swimming and yoga. I'm very passionate about keeping fit and active, but also about women's health issues and particularly pelvic floor problems. I'm also an ambassador for MASIC, which is why I'm here today, in my most significant role in all of this, because I'm a mum. So I'm 44 and 22 years ago, I gave birth to my only child. He was a large baby born extremely quickly, and I was induced. If you looked at the birth notes, it would state that I had a normal vaginal delivery. I didn't have any implements or devices. My son literally tore his way out. And I was told I had sustained second-degree perineal and vaginal tears. And we've already mentioned the perineum. So for people who are not sure where that is the space between the vagina and the anus. However, when it became to fixing the tears, the notes don't actually reflect what happened. And in reality, the two midwives that were looking after me were actually arguing over me as to how to do this repair. And I wasn't part of this discussion. One wanted to send me to surgical repair and have a blood transfusion. And the other one said, no, I can handle this. And so she did. So I left after that, being discharged from the hospital, extremely sore, bruised, swollen, all the things that you might associate because you've had stitches, but absolutely none the wiser that anything else had gone wrong. However, it was the repair, the whole birth experience, which was truly horrific, that was the pivotal turning point in my life, except I didn't know it. 18 months after I had my son, I developed stress urinary incontinence. So I had physiotherapy and biofeedback, lots of other tests, some quite humiliating. And ultimately it was decided that the best thing to fix me would be to put a TVT pelvic mesh in. So at age 24, I had one of those. 3 months after that is when I started developing problems with bowel incontinence. And I now know that's probably a term referred to as anal incontinence because it affects the anal sphincters and the pelvic nerves. These episodes of urgency would lead to incontinence and not just a small amount of leaking. I would be soiling myself regularly. I would have multiple trips to the loo during the mornings because I couldn't evacuate completely. I had incomplete evacuation. And despite the fact that I'd had this bladder repair and now I had this, I was still none the wiser that this was still linked to the birth. Because when I first was getting investigated for the anal incontinence, it was suggested that I might have IBS, or because I'd been on an overseas trip, I picked up a virus. However, these incidences got worse and worse and were severely impacting my life. And so I restarted physiotherapy, more tests, more treatment, anal biofeedback, and I ended up having rectocele repair, but from the anal side. It was at this point, 3 years down the line, I was beginning to think there's something really not right here, because despite having this, next repair, things were still a problem. And I requested an appointment with the consultant at the hospital where I'd had my son to ask, how have I got all these problems? Before I started this journey with my son, I was extremely fit, athletic, highly competitive. And if it wasn't for the issues that I talk about next, I probably would be some sort of athlete. And I was met with the response, well, you've had a traumatic birth. Everything's normal. You're psychologically scarred. You just need to get on with it. This will all go away in time. But unfortunately, these symptoms didn't go away. And actually, 20 years on, 17 operations later, my most recent being a colostomy last year, these problems didn't go away. In reality, they were very much a physical issue. I cannot describe for anybody who has never experienced it how distressing it is soiling yourself, having accidents. This whole experience doesn't only just impact on me, but those around me. So the lives of my husband and my son. I now know that my tear was more likely to have been a 3rd degree tear. It was probably underdiagnosed. And if my birth had been managed differently and that repair had been treated differently, that the outcome and the last 20 years of my life could have been very different. So I'm here to highlight how catastrophic these tears are at birth, how life-changing they are, how debilitating they are. The way I see it is you have one chance to get this right, and when it goes wrong, it goes horribly wrong. So you can't repair the damage done to people's lives, and you can't repair the emotional stress and trauma this places on a person when they're told these problems are psychological. You can't repair or undo what has happened. Living with lifelong incontinence is not a choice. You can try to treat it and manage the symptoms, but ultimately there is not a cure. And so I'm here representing MASIC and all the other mums that have suffered and are suffering and continue to do so, because despite my birth being 20 years ago, this is still happening today, and my circumstances are just as relevant now. I would really like the experience and the experience of all the other women who've had these issues to get out there, to be acknowledged, but not just be acknowledged. Use these situations and examples to show what improvement there needs to be in the outcomes for women with childbirth problems. And I'd see it as the 3 Ps ideally, and there's no pun intended because we're talking about incontinence here, but we need to promote, make women better aware of the risks of childbirth. We need to prevent at the time of birth these devastating tears from happening. Okay, we can't eradicate them all the time, but we can try and eliminate them as much as possible. And then protect the women who suffered these tears. Give them the best treatment possible, because these tears and the consequences of them might not present straight away. So the 3 Ps, because incontinence is no laughing matter. And now we're going to carry on having a discussion.
Thank you, Jo. You're incredibly brave to be able to share that story, and it's incredible what you've been through. And I think the 3 Ps is so good. And sadly for you, you've been let down by every P. And I'm just thinking about, you know, with hindsight, what you'd like to have known, but even now, actually, about the whole protection, because I always think you can't, someone said to me a while ago, you can glance back, you should glance back and look forwards. And I really think a lot with my patients who've been through so much, nobody wants to dwell on the past because we can't change the past, but a lot of the protection that you could have had might have been very different, both physical and psychological as well. And it really saddens me to hear that no one believed you. And, you know, as a medical practitioner, it's about believing and listening to patients, number one. And so I would just wonder, you know, what, you can't turn back the clocks and there's no point dwelling on it, I think, because that's not, but what else would you like to know? Or what do you think would be useful for people to know who are pregnant? Because everyone focuses on the baby, don't they? So is there anything that you would say?
I think it would be completely transparent for every woman, no matter if she's had a child before and had no issues, that incontinence is a risk of childbirth, whether it be bladder or bowel, and that these things can materialize immediately after birth, but it could be 2 to 5 years. It could be later in life, and that the connections between the two aren't often made the further away you get from the birth. I think awareness of pelvic floor exercises, but not just a generic sheet of pelvic floor exercises, women understanding properly how to perform them, being given proper training. And I think antenatally is probably one of the best times to target this, because if you are familiar with how your pelvic floor works, then you're in a far better position to use it when you need it post-baby. And also menopause age, you know, pelvic floor is with us for life, so we need to try and look after it, and it's a very undervalued muscle.
Absolutely, and we'll come back to the impact with the menopause. And I think the other thing is, you know, if someone did have a trauma at birth, it's not an emergency acute situation. It's really important that people often get a second opinion as well, I think.
And I think as well as the the risks of the incontinence side, it's discussing, if you have these various interventions, if you have forceps, if you have Ventouse, what can be the outcomes of all of these? How can they affect not just the perineum, but the whole area? So yeah, I think there needs to be greater awareness of the entire process.
Absolutely. So thank you very much. So Radhika, we've obviously you're a GP, and from a primary care perspective, obviously as GPs we don't see people who are in labour usually and deal with the immediate situation. But what's the experience that you've had seeing women who have had a perineal trauma or problems with continence following a delivery in your primary care practice?
Thank you. Thank you, Jo, and thank you, Louise. My experience, the challenge in the perspective of primary care on this is that we don't see women frequently enough. The same practitioner doesn't see them. So continuity is the biggest challenge that general practice faces. I know that's in every situation, but it's much more so for antenatal women, because really antenatal care is mainly managed by midwives. So the first thing that we can emphasize when you know someone from before is knowing their history from previous pregnancies, or their medical history otherwise, or their age-related history or obesity. Those sorts of factors make a difference. But at the moment, I think we're very much challenged by the care that we are able to provide, and not being able to see women face-to-face or examine them poses a whole new challenge, which is very difficult. So currently, we are probably much more led by a woman raising it herself, or during a quick postnatal check, there's a couple of tick boxes which we might ask, are there any bowel or urinary continence issues? And I think it's all about how you approach that. If you pause and give it long enough, and may perhaps say something along the lines of, this is very normal and it's a very common presentation after childbirth, or perhaps even much later. Have you experienced any of this? And much more women will step forward and say that. So like Jo said, it's about raising the awareness.
I think certainly when we do postnatal checks and 6 or 8 week baby checks, we're very much primed to asking about or screening for postnatal depression, aren't we? And I think you're absolutely right. If we could ask those questions to the mother, any bladder or bowel problems, and actually also talk to them about pelvic floor. So, for example, in France, they have a lot more training, don't they, with their pelvic floor when they're very young, but it certainly postpartum is a really good time to approach, and that wouldn't take very long, would it? And for the midwife or the GP that's doing the checks, just to say those questions would make a difference.
Absolutely. It's about normalizing it and also repeating it. Quite often things have to be said several times. So if we start antenatally and carry on postnatally and promote it like we do with contraception or feeding, and make it as part of the female's care for herself moving forward, we'll find in every sector and age group and ethnic minorities that women embrace the topic much more, and therefore know where to come or where to seek help when problems arise.
Yeah, and absolutely, and trying to seek help earlier rather than waiting as well. And you know, as healthcare professionals, we're not embarrassed talking about bodily functions, but for a lot of women, they might never have mentioned it to anyone before, even to their partners. So it's really important, like you say, the more it's asked, the more normalised as well. So yeah, that's really, really good advice. So Ranee, as a gynaecologist or obstetrician with a secondary care head on, I'm sure you've heard stories like this far too often in your clinical practice, and which is very frustrating and sad. But what would be your sort of thoughts after listening to Jo's story?
I think that to deal with this problem, we need to not compartmentalize it. So it's not about primary care, it's not about secondary care. It's not about nurses, midwives, or doctors. I think it's everybody's business. In middle of it is our patient, and then we have all the health professionals. And we need to focus on our patient. So I would say it's everybody's business. That practice nurse, when she's doing smears, for example, ask it's just two questions. Do you have bladder and bowel incontinence? The midwife who sees the patient in the antenatal period or even during parent craft, talk about this. This is not a topic that is discussed even by midwives. Obstetricians, again, we talk about the baby, we focus about the baby. But what we need to do, it needs to be part of everybody's business, and we need to break those barriers. And the reason why we haven't dealt with this issue very well is because we have these barriers. How we deal with it, I would like to focus on the 3Ps. I love the 3Ps, Joe. And Joe, I have to say, I applaud you for sharing that story. I hear this story all the time in my practice because I have an interest in childbirth trauma. And many women take a long time to complain about this. And as a urogynecologist, I see them at all spectrums of their life. Women who have had anal sphincter injuries during childbirth often do not get symptoms immediately afterwards, but as they go into the menopause, symptoms start manifesting. So therefore, remember that it can occur anywhere along the life course of a woman. Coming to your promotion, again, we need to empower women. And as healthcare professions, I think that's our business as well. Empower women. They need to ask us, then it will become everybody's business. Prevention is something I'm really, really focused on. And as midwives, as obstetricians, there's a lot that we can do during labor. Episiotomy, which is a cut done to the perineum, needs to be done when indicated and done correctly. So we do know that when it's angled to the center, you're at high incidence of getting injury to the anal sphincter, which can later on lead to incontinence. Another area of great interest, which is hugely debated, is manual perineal protection during delivery. So putting the hand on the perineum when the baby is being delivered in the second stage. And for some reason, based on some publication, a lot of midwives and doctors stopped doing this. So much so that we have seen an increase in the rates of anal sphincter injuries. Now there is some evidence from Scandinavia that has shown that doing this is actually protective. Also, the choice of instrument that is used during delivery of the baby. So ventouses or vacuum should be preferred over a forceps. Obviously, it also depends on the doctor, the practitioner who's doing it, and the circumstances. But when you can, a ventouse should be used. And if I can just bring in some of the latest work that we have done between the Royal College of Midwives and the RCOG, that's the Royal College of Obstetricians and Gynaecologists, we introduced a care bundle which included providing antenatal information, manual perineal protection, episiotomy, and doing a rectal examination. And we introduced this in 16 units in the UK, and we found a 20% reduction in OAC rates. And this has just been published. So that's quite a positive story. But to this, I would like to add diagnosis, because that is so important, doing a rectal examination to get the diagnosis right. And last but not least was the protection. It's our duty to protect these women. We need to give them information, empower them, and make sure that they're seen by the right person.
Absolutely. And it's very interesting, isn't it? Because you were saying about it, the presentation doesn't always occur straight after the baby's born. And for some women, actually, you're saying about the menopause. And so some people might be listening thinking, well, we're talking about childbirth and I'm here as a menopause specialist. What am I doing here? But I've already said how important estrogen is, but it's very important in all the vulval tissues, the vaginal tissues, the pelvic floor, even around the anus. We have estrogen that gets everywhere as women, and without it, there's real changes, aren't they, to these tissues? Do you mind just explaining what happens without estrogen?
So obviously, as you go into the menopause, your estrogen levels go down, your muscles become become more weak. Your collagen tissue changes, not only in content, but type of collagen, and therefore the symptoms start manifesting. What you've got to remember is that as the baby comes out to the vagina, it all stretches. And symptoms do not manifest immediately afterwards in most women. They become evident later on in life.
Absolutely. So I see quite a few women in my clinic who have just about got through, they've been all right, and then the menopause comes, but then often they don't realise it's related to the menopause. They think it's because they're getting older, and they're a bit of leakage, a bit of incontinence, they just think, well, that's just part of getting older. And then you look at them and they're in their 40s, 50s, 60s, that's not old. No one should have incontinence without realising and knowing that there's treatment available. So it's something that often can just rear its head, and it's something that we need to think about even more, don't we? So Jo, back to you again. You've obviously been through so many operations, as you've said, and various treatments. I dread to think how many healthcare professionals you must have seen, but it's a huge number. And I know when I've had various experiences as a patient, it's sometimes actually the very small things that make the biggest difference. Someone just introducing their name or saying who they are or how they can help you actually can be more than someone making a diagnosis or giving you life-saving treatment. So what's been your sort of biggest frustration with everything, if you don't mind me asking?
I think there's a few frustrations. There's definitely more than one. One I would say is, when somebody's telling you something very personal, is give them eye contact for a start. Now, I know this can be tricky when you're making notes, but you do need to stop and look at the person and look at them as they're telling you these awful things, because it makes you feel like you are being understood. Secondly, I would say continuity of care is paramount. Now, unfortunately, with the way most hospitals are run and resources and the rest of it, is you will turn up to one clinic and see one person. You might not have another appointment for 18 months. You turn up at that clinic and the person you thought you're going to see is not the one you see after all. This leads me on to a second point. So when you have multiple problems like I had, where you definitely need colorectal department and urogynecology working together, it's having that cohesive discretion between the two and not becoming Hadrian's Wall, where urogynecology are doing things on one side and you've got colorectal doing something on the other side. The two need to link up and communicate and talk to each other. And if you promise a patient that they're going to have an MDT meeting about you, then you really want to make sure that happens before they turn up at the next appointment, rather than saying, never met you before, have no idea why you're here. Can you tell me why you're here? It's so demoralizing as a patient to turn up and be no further forward after an 18-month lapse. It really is. I mean, it's you go away and you just sink. It's a horrible sensation. And these women wait months for these appointments. And obviously now it's a lot harder with COVID. And so that would, I would say, is another big frustration. So join the dots up, have the communication between the departments. And the other one is, which I think any person with some sort of chronic condition would face, is hospital administration systems, where you have the administration systems where the appointments are just a nightmare to deal with. They are really frustrating as a patient, but I appreciate that isn't just for urogynecology and
yeah, but it's all about making the patient journey a positive one, isn't it? Which is so important. And even if you haven't got necessarily the right knowledge or the right treatment, it's about making the patient feel very individual. And certainly, I mean, I work out the menopause guidelines from NICE, the National Institute of Health and Care Excellence, and they're very key that women should have individualised care. But that's not just about the menopause. Anything we should feel individualised. And I think it's really important, isn't it, that we're all listened to. And I find doing the screen consultations, they can be convenient, but they're very hard, because when a patient bursts into tears, which often they do, I can't give them a tissue. It's very difficult. You can't read how they're feeling. And sometimes we don't even know where to look on the screen for even eye contact. So it's very artificial, but actually you can get round it. And I think it's being, for us as practitioners, to be really open. And there are certain ways, if there are failings in the system, we don't need to dwell on every aspect of the failings, but we need to admit there's been failings and apologise. And I think that's really important as well. We don't need to be pointing fingers. We wouldn't want to say anything rude about other doctors or practitioners, but what we want to do is work together and focus on going forward with that patient. And I think that makes a huge difference, and you want to feel confident, don't you? I think as a patient, we want to
Definitely, yeah.
feel we've been listened to is really important. So, Radhika, as a primary care physician, if you've seen, or I'm sure you have seen people similar to Jo in your practice, what would you think? What would you do, and how would you approach a problem like this?
Thank you. I think it's really important to focus that this is a really difficult journey, and the services are not optimal, but we can work with a lot, and we have it there, and we need to utilize these things better. So one of the first things is, amongst promotion in one of Jo's P's, I would say, is education of clinicians and professionals that are involved in this, whether they're midwives or doctors. As an educator, that's something I'm really passionate about. I think if we start to change the baseline approach that we have, we will then educate and move forward to improve the services we provide, and then identify what we need to make better if we're doing it well enough. But if I had seen Jo early on in primary care, one of the main things I would have done is build a rapport with her. And that's relatively easy for me, but I think that, of course, COVID makes it tricky. But if we can just be honest and say the key question of how has your life changed? What can't you do that you used to do? And we can do that with any disease, but I think in this context, we need to separate mother from person and deal with the person who is having the problem. It's not the baby's check, we're talking about the perineal injury. The other main fundamental thing is, although sometimes you can ask the questions, it used to be part of every postnatal check, but it no longer is, but it is thinking about a vaginal exam. It's explaining the importance of that. Obviously feeling competent in how you're doing it, but it's a really, really important examination, and it's really important it's done and documented, because if things change further down the years, you've got that documented. There's the ones that Jo has already mentioned, like pelvic physio and understanding pelvic floor exercises so you're doing them correctly, because quite with respect, with no blame placed on them, don't understand what they're doing. The other thing is thinking about vaginal estrogen that can be helpful, but also using the continence services that we have, which I know vary postcode to postcode, but we have urinary and fecal incontinence services that we can access. Now, the brilliant thing about these is they're available to GPs. We can then provide a baseline level of investigations or tests, which can then filter off who needs to be seen further. So I think it's really important to use the services we have, ask the questions, build the rapport, so a woman feels like she can, if she can't say it on this sitting, she's going to go home, reflect on it, and perhaps next time feel, no, I'm not going to live with this, and then come back with it.
Really useful advice, thank you. And in your experience, is there a difference, you think, with different women? So women from different backgrounds, so socioeconomic backgrounds, but also ethnic minorities. Are certain groups of women less likely to come forward, do you think?
No, thank you, Louise. I mean, absolutely. And this is something that's so crucially important. We've seen recently that women from Black, Asian and minority ethnic groups are at a higher prenatal and postnatal risk categories for complications, but they certainly do not seek help for perineal injury as well, as much as other groups. Partly it's because there's a cultural hesitation towards examination, and that can be alleviated by explanation. And there's also a lot of living with a lot of embarrassing symptoms. And, we know now women are living such a long life that if they're spending a good 30, 40 years living with incontinence, that can be helped. And I also feel that something that recently came up is there's a culture of accepting that incontinence. And I think we need to address that, because from a quality of life point of view, it can make a huge difference. It can socially isolate, as Jo has mentioned. And reaching out to the Black, Asian and minority ethnic groups to seek help for this is something that we can group educate very quickly. And we know from a community setting, information can cascade very quickly. Yes. So our work can be done for us very nicely if we do it well at the beginning.
Absolutely. And it is so important, because there is so much stigma, there's so much embarrassment. And I'm actually quite surprised as a doctor. I often offer to examine women, and so many say, really, are you sure? And of course, and you can see their shoulders go down quite a few inches just because you've asked that question. And it's also quite surprising that they've never been examined before, and it's not because they don't want to, and it's very easy to misjudge that as well, isn't it? So, and I think you're absolutely right, but certainly when people go through the menopause as well, that's not spoken about, and like we've said already about incontinence, but that's often linked with vaginal dryness, which again is due to lack of estrogen. And I see a lot of women who can't sit down, they can't wear underclothes, it's so uncomfortable, yet they've never spoken to anyone because they think that this is just part of getting older, and a lot of these women aren't old at all. You mentioned something about vaginal estrogen. That's different to HRT, isn't it? Do you mind just explaining what vaginal estrogen is?
Absolutely. So vaginal estrogen comes, the vaginal tissue and all the pelvic area is enriched with estrogen receptors. We've already mentioned that, but it's really important. We've mentioned how birth affects that, but even moving forward, just the general rigmarole of living and using this tissue from a menstruation point of view, or for sexual function, or for bowel function, we're using those estrogen receptors as their function all the time, and they will fluctuate. So we can get vaginal estrogen as a pessary, which is a little tablet which comes in an applicator or as a cream. It needs to be prescribed, and it's really important that it's prescribed accordingly and you're confident in how you're using it, because actually on the whole it's incredibly safe. And it can help a lot of women. And for many women in primary care who are seen with recurrent bouts of what they call cystitis, and they suspect they're getting recurrent urine infections, it can be really, really useful. So I think it's a really important tool to use because we have it. It's very effective for many women and really safe to use. And, it's independent from HRT.
Yes, so it's only working locally in the tissues, and it's not just used for people in menopause. A lot of perimenopausal women, so these are women who are experiencing some symptoms before their periods stop, but also postpartum. There's a massive decline in estrogen, isn't there? Women who are pregnant have a lot of estrogen, so it can still be used at other times, and it's important maybe for women to bring up the conversation with their doctors or nurses or even their midwives, because they might not necessarily think about it. So there's no harm in having local estrogen, is there?
And I think it's a really important to raise right now, because as postnatal checks may not be 6 weeks, we're finding the dates are moving more and more forward. We know there's a natural predictable time space in healing. So if you're seeing women at 10 weeks or beyond who are saying they're continually uncomfortable with issues or discomfort with urination or sitting or wearing clothing, we know that's the group that vaginal estrogen can make a huge difference in. And you can give them a trial and then see them again, and or discuss it again and then see the difference. And it's also giving a woman some control over her body very nicely, very early on when she feels quite vulnerable. Yeah. And I think that's a huge source of empowerment.
Absolutely, definitely. So Ranee, I presume you agree with everything we're saying, but as a secondary case, someone in hospital, how would the sort of ideal sort of scenario really for Jo be? We've talked about MDT meetings and how we don't always join the dots. Is there any advice that you could give, or what you would say about moving things forward if a patient like Jo presented to you?
I mean, Jo's story is horrendous. It gives me goosebumps to just think that such a thing could happen. But that is reality. That's part of the NHS. It's our job to fix it. And there were two things that were mentioned, and I like to say again, what patients like Jo want is honesty. They want to be told what's happened and not just hiding things under the carpet. And they want an apology. And they want to make sure that this doesn't happen to another person. And that's the kind of people I meet all the time. When they complain, they're not complaining because they're complaining kind of person. They don't want this to happen to another person. And that is the bottom line where they come from. An ideal setting would be one where Jo or somebody like Jo seems the same healthcare professional throughout her journey. And I'd just like to share you how we have designed our service in Croydon University Hospital. So I run a perineal clinic where I see patients who have postpartum problems. We have a one-stop clinic. I do the history. I've been trained to do endoanal ultrasound scan, which is a scan of the anal sphincter. I've been trained to do a pelvic floor scan, so we looked at the levator muscles as well, if necessary, and we also measure the pressures of the pelvic floor. Now, if everything's fine, we advise them to do pelvic floor muscle exercises. But if they do not, if they, for example, have anal incontinence, that is leakage from the back passage, they would then see our colorectal nurse and have supervised pelvic floor muscle exercises, advice, so on and so forth. And she would then discharge them when they're better. However, if she does not get better, her incontinence does not improve, they would be seen in what we call a joint pelvic floor clinic, which is run by myself and the colorectal surgeon. And then we would institute treatment. Usually by the time they've come to me from the nurse, it will be surgical treatment. So say, for example, if the sphincter needs to be fixed, we would fix it in theatre together, and then the follow-up is again done by the same team. So Jo would hardly ever see the different kind of healthcare professionals that she sees. One person doing the scan, a different registrar, a different healthcare professional. So we do a joint pelvic floor clinic, and the MDT is done by the same people. And Jo is absolutely right. She should not be contacted again without doing that MDT, and she should be told what was discussed in that MDT. It's all about honesty.
Absolutely, but it seems an amazing service that you provide, but I wonder if all hospitals provide such an incredible service, because I don't think they do. It's a huge way to go. Yeah. But it is so important, isn't it? Like you say, I think honesty is number one. And if the person isn't having the right service, then they can always ask for a referral somewhere else, can't they? And I think that's really important, that women know that they feel they want to be referred to somewhere else, or a different hospital, or for a second opinion. That's okay, isn't it? And do we have any knowledge on the percentage of women that are affected with perineal trauma that causes problems? Is there any data at all about how common? Obviously, there's different degrees, but...
Yeah, so recognized anal sphincter injury occurs in about 2.5 to 3% of women. I almost do not worry that much about the recognized ones, because they get sutured on labor ward or in theatre. The ones that I worry about are the unrecognized ones. The women who think that they have had no tear, or they've had a second degree tear, but actually they have anal sphincter injury. They go home and then they get anal incontinence. And that's a complete shock, especially if you're a first-time mother. And I think therefore we need to inform mother in the antenatal period that a tear can occur. Often patients will tell me, nobody ever talked to me that I could get an anal sphincter injury. I could get a tear down below, which could lead to dyspareunia or pain during sexual intercourse. We need to empower women by giving them the information. Often we are frightened to tell patients about these symptoms can occur, because we think that they're going to be frightened. But in our trial that we did, or the quality improvement program, women actually wanted to know. They wanted to know that things can go wrong. They also wanted to know, they also felt that having an anal sphincter examination at the time of the childbirth was perfectly okay. They just wanted consent, they wanted it to be explained to them, and they didn't object. Whereas healthcare professionals are actually a little bit timid, and they feel that they do not want to do a per rectal examination because women will mind. Women do not mind.
No, and I think it goes to the first P about promotion and awareness. And I'm very fortunate. I had 3 pregnancies, and each time it was all about having a really positive birthing experience. And I had an emergency section with my first, and I was made by some baby groups to feel a failure, actually. And I didn't feel a failure because I had a healthy baby. But it was all about the birth, and it was all about my analgesia that I wanted, whether I wanted an epidural or not. And deep down, I was worried about my pelvic floor, actually, because I've done some obstetrics and I've seen some injuries, but no one talked to me that that was even a possibility. And you're quite right, you know, it's our bodies we need to know, but I think also we need to know any injury, there's a possibility that it's going to rear its head again during the perimenopause and menopause. Because this is a time, as you know, with lack of estrogen in the brain, often people feel very vulnerable. They have reduced self-esteem. They often have other symptoms that are affecting their ability to function and actually perform as a woman and perform in the workplace, just day to day. Life can be really difficult. And then if you're experiencing some symptoms such as incontinence, it's even more degrading, and you're not expecting, and you're not linking it back to anything from before. And then how do you tell someone about that? So actually to have that knowledge from very early on, you might then remember, oh yes, my midwife told me this might happen to me during the menopause or the perimenopause. So sorry, Jo, were you going to say something?
I just wanted to add something into Renee's comment about, you know, one digital rectal exam. And I think the key thing that most of the mums in my situation would say is we've had to have so many rectal examinations, all sorts of balloons, tubes, catheters, multiple times for the sake of one digital rectal exam. I think we'd all put our hand up and say, yes, please.
Yeah, absolutely. So it's so important. So coming back to you, Jo, we want to, I certainly feel a lot of my work that I'm doing about the menopause is about empowering women, also men, because men know women, so they can help along the journey. It's not just about women here. And certainly when I was training as a doctor in the 80s and 90s, it was very paternalistic. I'm the doctor, you're the patient, I will tell you what to do. Thankfully, that has changed, and it's changed to almost 180 degrees, whereas now the patient becomes first. And it's not a patient with a disease. It's a patient who happens to have a disease, but she also has a life. And it's making the bigger picture, you know, is so important for us as doctors. But I feel like the more we can empower our patients, the more that they can actually help the consultation, they can help the direction. And I think even now when we're seeing different healthcare professionals all the time, with the way that NHS is becoming very fragmented, it's even more crucial that we are feeling empowered. But that's hard. I know it's hard. I go to pieces when I see a doctor because I feel I'm wasting their time. How do you think awareness can be increased so women can feel empowered?
Well, I think like the work that MASIC is doing, particularly with trying to support women who've had these sort of birth injuries by promoting and educating the clinicians, trying to get positive change like the Oasi Care bundle. Really, I think women need to talk to other women as well, highlight their experiences. And actually, if you get a couple of women together and one starts off the conversation, you'll find that more will join in. So it's sort of having that collective awareness, talking to each other about the problem.
And it's not feeling alone, isn't it? I think when you have a problem and no one else you know in your immediate supportive group have it, well then who do you go to? So actually to have other people is really important.
Yeah, and I think I'd also like to highlight, you know how you said it, talk in reference to disease. Well, unfortunately, this isn't a disease, and I sometimes feel like because it's not, it's an inconvenience. And so in terms of clinical priority, it's not given the priority it might be given because we're seen as a nuisance issue rather than a life-threatening issue. But actually it does threaten lives because people can get very low, and some people would be very suicidal at times with this. So
absolutely, and I think this is
that mental health support there too.
And this is a reflection of women's health in general, isn't it? Women's health is not a priority at all. And then you look at other areas, like you say, that aren't diseases. You know, the menopause isn't a disease, it's a natural process, but it can lead to disease if it's inadequately managed. But it's the psychological impact of any condition, any trauma, anything that can really affect people. And that needs to be addressed as well, because, you know, it's a very vulnerable time of your lives, and if it's not addressed properly, then it can be compounded and made worse. And the thought of women going through experiences like yours in isolation is horrific in my mind. And we know it happens in all corners of the globe, and it needs to be addressed. So, you know, the work the charity does is instrumental, isn't it, of bringing women together.
And I think there is probably a lot of isolation for older women too, because I think with younger women, they might be more inclined to use social media as a route for finding support groups. But I speak to quite a lot of older women in their 60s who are dealing with this. And I might be the first person they've ever talked to outside of their families about it. And they just feel so relieved to be able to actually offload to somebody else. But I think there is a huge part of our demographic there that are under-supported. And reaching them and letting them know that there's a network that they could access. It's so quite hard to reach them.
Absolutely. So Radhika, in primary care, how do you think we should be working to improve awareness of this in women, but for men to recognise it in their partners as well?
I think it needs to be part of prenatal conversation, and it has to be recognised as something that we flag up when we talk about preconceptually, which we don't do as thoroughly as other Western countries in England or in the UK. But perhaps if we change that perspective on the ground, we can approach it better in the future. So when we're talking to women saying, do you smoke, do you drink, or prenatally, we need to approach the risk factors, which we know are constipation, weight, multiple births quickly, having a pregnancy in an older age, or Black and Asian minority groups, and have a look at those risk factors and assess them. That will allow us to have some baseline control in terms of what a woman can change immediately. Secondly, I think professional education for doctors, midwives, and you talked about being at medical school, Louise, but I was at medical school in the late 90s, and I don't remember women's health being taught in a problem-based life way. It was taught in a textbook manner, and it followed a systematic approach, which we know real life doesn't. So I think we need to approach our education of professionals as a problem-based approach. These are the problems we have in our current society for women. How do we approach these? And we need to make those consultations count. And the third thing I must say for my GP colleagues is we can feel utterly overwhelmed, and nobody goes into work to say, how can I undertreat women? But increasing the awareness of the services out there, if we can get the primary and the secondary talking to each other to say, this is what we offer for women who have these injuries, please refer, or please don't be hesitant to refer, particularly because you can't see them currently because of COVID. If you have concerns, do refer, then that's really important. And from an education point of view, an area I'm really passionate about is, it breaks my heart when I see women for the first time for a pessary, for their prolapse or for their incontinence, and they've lived with it all their life, and that's what they feel is their only option, which often is the case. But there's a huge amount of contacts in between with different professionals when that could have been raised. And Ranee alluded to that with smears, health checks or medication checks. And I think it's just becoming more aware and comfortable to talk about it. And quite often, like you say, when it's raised, women are not hesitant. I think if we become less uncomfortable, they will become more comfortable to answer, because they do place their trust in us.
Absolutely, and it's totally right, and it's trying to bring up as much as possible in a consultation. And I know it's very difficult when you only have a 10-minute consultation, but it doesn't take long to ask a few questions. And I was doing a podcast recently with an eminent professor from America talking about vaginal dryness, and he actually said one of the questions he just asked is, has it felt any different for you around in the vagina, rather than has it been sore, has it been painful, has it felt different? And I thought, what a great word, different. It's just using the right words to and the right language. Some people I've spoken to, and I've lectured different healthcare professionals, nurses and doctors, who said, well, I'll only ask a woman if she's sexually active. Well, that's irrelevant. Every woman sits down. Every woman wants to wear underclothes. So it's key but the more the conversation is there, then the easier it is for them to address a problem if it comes. And it's trying to prevent it becoming a bigger problem as well, isn't it? It's really important.
Absolutely. And I think that what I would really encourage it for is that if we approach it first, we won't end up with situations when women are absolutely desperate, coming in with reams of paper or saying, can I have this? Or completely lost faith in the system. And I think we have a fantastic healthcare system that we're trying to work the best we can. And but if we can break it down into lifestyle measures that we can assess prenatally, antenatal, all the professionals involved, and there's quite a huge concentration all of a sudden for many healthy women who've never had contact antenatally. It's a really good opportunity, and then postnatally in primary care, and get those join all those dots together. I think we can offer better care. And it breaks my heart when I see women who, have been in multiple times, and the services are there. We need to use the services we do have to know what we need further.
Absolutely, and I'm very conscious we're talking a lot about GPs, but it's not just GPs, and so certainly to improve awareness and education, Ranee, for GPs, for healthcare professionals, doctors in secondary care, for student doctors, are there ways, are there things happening, or what would you like to see happening to improve?
So there's absolutely no doubt that this is a poorly covered topic, and it needs to be included in undergraduate teaching and postgraduate teaching. And as you said, it's often about how you ask these questions. Women are embarrassed to talk about this. They think it's part of growing old or consequence of life. But if we approach it, if doctors are taught how to deal with this problem, and sometimes doctors don't ask because they don't know what to do about the problem. So you'd rather not ask. So the thing is, training of doctors starting right undergraduate, postgraduate, so they are able to ask their question and deal with the problem. They don't have to actually provide the treatment, but direct the patient to the right person. And that's where that could be a practice nurse, it could be the nurses in the community, and then they also need to be educated about this. Providing them a pad or asking them to go and buy Tena Lady is not the solution. The solution is then them knowing where to direct the patient to, the right continence service. And again, continence services in this country are fragmented, and that's really sad. The other area that needs to improve is our midwifery colleagues. Though there is a lot of improvement currently, we do know that it is a very poorly covered topic in their curriculum. It almost doesn't exist. Or let us say the curriculum is different in different parts, different universities, and therefore it's not standardized. And this is something that we have been discussing with the Royal College of Midwives currently. It may surprise you that once a woman has a tear, the midwife almost never sees them after a few weeks. So they actually do not see Joe and people like Joe. And this is the problem. I think they need to hear more of these stories to increase their awareness, because when they do see something like this, they're horrified. They need to come and sit in my clinic. And see what happens to the patient, and that's something that we are trying to do in our practice. Again, people are frightened. Midwives are nervous to tell women in the antenatal period about the consequences. But there is a way of explaining it to them without scaremongering. They are frightened that women will be scared, but women actually want to know.
Yeah, absolutely. And I think, we've talked about this a lot, haven't we, about honesty. And we're human beings. We don't know everything. And certainly as GPs or practice nurses, we're quite generalist. So there are lots of times when people come with me with a symptom or a problem or even a disease that I don't know how best to manage. But actually, they really respect it when I'm saying, I share that uncertainty and say, I'm really sorry, I don't know, but I can find out. I will refer you, or I'll find out who the best person is or what the treatment is. And I think that's really important, that and then we feel confident in that person, even though that person doesn't know the answer, which is a strange thing, I think, for healthcare professionals learning, because we feel that we should always know the answer. And obviously, everyone's different and we don't. So, but education early on is really important. And I think it's so valid what you're saying about midwives, because they feel they've done the best job, because maybe cosmetically it looks fine, maybe that vagina looks like it's going to heal very healthily, but they don't see the long-term consequences. And that's the problem. I had no idea how common symptoms related to vaginal dryness were until I started seeing hundreds of women in my clinic every month. And we know from some studies that 80% of women after the menopause have symptoms related to vaginal dryness, yet only about 8% have treatment. And that's not because they don't want it. Sometimes, as studies have shown, about 20–30% of women bring it up in the consultation, but they don't actually go away with any treatment. So there's a lot that needs to be done. It really is. So, I mean, this last hour has been really so informative, and it's been fantastic. You know, Jo, you're so brave sharing your story, and I really commend you for it. But we have learned so much from it, because from doctors, I learn every day from my patients. I've learned more from my patients than I have from any textbook or any article that I've read. So it really has been informative. But I want to spend some time, if it's okay. We've had quite a few questions, which is fantastic. Some of them are themed, but I'm going to go through them in order because I think that's better, but some of them I will group together. So the first one actually is just a comment, but I want to share it. It says, thank you, Jo, for sharing your story. As someone who also has had a long journey with problems, most likely from childbirth, I think it's so important to get the message out there and encourage women to speak up for help, which I absolutely agree. I have a colostomy for life, but I would choose that any day over continence issues. And I think, yeah, I mean, you're nodding. I don't know if you've got a comment to add to that, Jo.
I would say my surgery has been life-changing. And one of the questions I've got asked recently is, do I wish I'd had it sooner? Now, this is an interesting conversation because I had exhausted a lot of other treatments prior to getting colostomy. And I think it depends where you are at that point. If you think there's a more minimally invasive treatment that may just happen to work for you, which is how I've exhausted so many avenues, I've gone for that option. And certainly 5–6 years ago, I wouldn't have been ready. But now, last year, I was more than ready, and I've seen how life-changing it's been. And honestly, I just feel like I'm starting in my 20s over again now. So it's taken, you know, that length of time, but I can now do what I probably wanted to do 20 years ago.
And and I think that's the other thing, isn't it? As healthcare professionals, no decision is set in concrete. You know, what a patient tells me 6 months ago and what they tell me now, often quite different, but that's okay. We change our cars, we move house, we're allowed to change what we want to do, you know, for treatment. And I think as patients shouldn't feel embarrassed, they shouldn't also feel that they need to please that person in front of them. They shouldn't do what they feel is right. And like you say, with maturity sometimes, or other life experiences, you might change your mind, and that's really key. So yeah, thank you very much for sharing that.
Going back to one other point with colostomy, I think before, when it had been mentioned maybe 6 years ago for me as a possible, the surgeon himself wasn't quite at the point where he felt like he wanted to put that in me. I think partly it was my age, all the rest of it, and him thinking, well, you're the same age as maybe my daughter or whatever, you know, I don't want to do that to you. And it was always perceived that it was the end of the road treatment. You know, you'd reached the end of the road, and actually my surgeon was very positive about it. And by making it the start of a new journey, start of a new life, it enabled me to be much more accepting of going for that decision. So I think how things are phrased is highly important when talking to patients, and how that perception is then formed in that patient's mind.
Yeah, which is so important, because, you know, we only live once, don't we? We've got to make the most of each day, really, which isn't always easy, I know. So next question. Someone says here, I don't know whether maybe you could answer this, Ranee, that I share your opinion that the risk of childbirth and importance of pelvic floor exercises antenatally. How do we get past the perception that we do not want to scare women antenatally, and equally that information on the pelvic floor isn't just brushed off by women?
You're right. Pelvic floor muscle exercises are as good as the person who instructs and as good as the patient's uptake and compliance. You're absolutely right about the scaremongering, which is what I mentioned earlier. But women want us to be honest. They want to know. And it's how we talk to them and how we explain it to them. And I'll tell you that most women want to know what happens during childbirth. So I actually think it's the way we frame, the way we talk to them, being honest, at the same time kind and compassionate.
Yeah, but actually pelvic floor exercises shouldn't be the first time that a woman hears about them when they're pregnant, should they? I mean, you should have good pelvic floor before you become pregnant. That would help, wouldn't it?
Do you know what, Louise? I have a theory. I think they should be taught in school.
Yeah, absolutely.
And you know, we teach them how to do exercise. I often tell them, you know, just like you do the exercise, you want to get your biceps right, you want to get your pelvic floor right.
I've got a lot of patients who are great athletes, they're really good sports people, they do a lot of running, but their pelvic floor is awful. They've never thought about it. It's such an important group of muscles. So it needs to be normalized, doesn't it? And be made part of everyday life.
Yeah, if I could just add to that, Louise, there is a big problem with pelvic floor muscle exercise in that we do not have enough pelvic floor muscle, pelvic floor physiotherapists. They're just not around, they're not enough for the amount we need. And so NHS England are actually working on a project based on what we know from France. As you mentioned earlier, they get free physiotherapy, pelvic floor muscle exercises for 6 weeks after. And I know that NHS England, because I'm part of their group, are looking at trying to make this a national thing in this country. But we do know that there are not enough physiotherapists. So we are looking at models wherein we train midwives to teach pelvic floor muscle exercise. But this is just work ongoing. So there is increased awareness and things should hopefully get better.
Hopefully. So yes, so someone has put a comment really that some good news that pelvic floor exercises for all women during and after pregnancy are part of the NHS long-term plan by 2023. So
yes,
still a few years.
That's what I was
it's talking about it and normalising it. And in fact, some of you might be aware of Jane Simpson's book, the Pelvic Floor Guide, which has been published by Penguin, and that's fantastic. You know, for Penguin to produce a book on pelvic floor would never have happened, I don't think, 5-10 years ago. So that's really good. So Radhika, this question's for you. As a colorectal surgeon who sees many women with perineal trauma after childbirth who struggle to talk about the consequences, what can we do about identifying anal and urinary incontinence as a formal ask at the 6-week check? And I know we did mention this, but can you just repeat those two questions? Because I think every person should be asked them.
Absolutely. I mean, I agree with you. They should be asked. I think it needs to be not that direct a question and not a closed question. I mean, like I said, it's a tick box on the postnatal check of urinary incontinence and fecal incontinence, and if it's there or if it's not. And you know, often it's a whistle stopper working through it. Time is pressured, so I would make it much more an open question of how are you with your bowel? Yeah. How are your bowel? How is your urinary function? And I think that compels a woman to say, well, actually, it's fine, but I have to time when I go out, or I have to be careful when I laugh or when I sneeze. And that gives you much more of an indication, because often it's what do people understand by incontinence? And I think that, you know, it's a really important distinction to make. A medical understanding might be very different from the patient's.
Absolutely, and I think a lot of people think incontinence is only bowel. They don't think about urinary, or they think they have to empty their entire bladder on the floor and then they're incontinent. But a little bit of leakage in their pants is not going to be incontinence, and so it's really important, isn't it?
Even when they present later, they'll say, "Well, I've always done that for many. I've had that problem for 20. I've had that for 20 years. That's normal me." Yes, this is me. And you kind of actually know that wasn't normal. And I think it's really difficult because it's hard not to make someone sad about what they've lived with. And I think it comes back to that point of raising awareness early enough to emphasize what is normal. And I think if we taught it in school or in secondary school level, girls would have a very clear understanding of, if they had a reasonable pelvic floor, how they felt. So when things go wrong, they can recognize.
Absolutely. I mean, there's been, Diane Danzebrink has a hashtag Make Menopause Matter campaign, and we've got secondary education now on the menopause. But actually, you know, the children know about periods, but they should know about pelvic floor. They don't even probably taught where those muscles are. So yeah, very important. Absolutely. So there's a few questions about vaginal estrogen, and I know we've mentioned them. So somebody has said the use of local estrogen in postnatal women to help with symptoms of prolapse and improve tissue quality. Is there much can be done for webbing and associated thin perineum after episiotomy or tear? Should we be referring these clients to perineal clinics? So can I ask you, Ranee, this obviously two questions, local estrogen postnatal women? Should we even consider using them routinely for a short period of time? And what about for the thinning of the perineum?
I think routine use would be an overkill. I would use it in those women who have problems, and you'll usually find that in those who are breastfeeding, because they have a reduction in the estrogen level. So it's that group of women that I would use local estrogen in.
Yeah.
The ones with a short perineum and with webbing, certainly they should be referred to a perineal clinic. It's important to have heightened suspicion if they have a short perineum, because they're likely to have anal sphincter injury as well. So it's definitely worth referring them, because then they can have a scan and we can rule out if there is any abnormality of the sphincter as well. And also to bear in mind that often these women feel that they look abnormal down below as well, because there's nothing between the anal canal and the vagina. So sometimes we can reconstruct that as well.
So really important to be referred, and sometimes it's not even the woman that notices, isn't it? It can be the partner, and it can be really important to make partners, male and female partners, completely aware that these changes, obviously the anatomy can change after having given birth, but if they're concerned, then you have to listen to the partner as well, because it's often can be from them, can't it, as well?
Yeah. And if I can say that the webbing that can sometimes occur after childbirth is very, very painful for women. And all we need to do sometimes is just divide it with local anesthetic in clinic. And I've seen women completely devastated when they come to the clinic. And all you need to, and nobody has ever looked at their perineum. They've been to GPs, they've had a chat with them, they've spoken to their midwives. Nobody has looked down there. And all it is a little web that needs a division under local anesthetic. So do examine women in the postnatal period.
Yeah, and I think for women, if they're not examined, they can ask. They're allowed to ask, aren't they? Yeah. And even if the doctor can't do it because it's not face-to-face or they're running out of time, that doctor or the healthcare professional can make another appointment. And so they shouldn't be going without knowing that they've either been examined or they can be examined. So question for you, Radhika, here about estrogen. So someone said, how long before estrogen shows its effects? I presume they mean vaginal estrogen, but also some women, especially menopausal women, as you know, the benefits of taking HRT outweigh any risks. So a lot of women have systemic HRT to improve their other symptoms that we've mentioned earlier, but about a fifth of women need vaginal estrogen as well. So if you were starting someone on HRT or using vaginal estrogen, how long would you leave it before you would assess to see whether you think that had helped?
Yep. So the way we would usually prescribe it is quite important to understand. So at the beginning, we would say use it every night for 2 weeks. And in that, you have a bit of a quick response and a loading, as we call it, of the dose. And then you would drop down to twice a week. Now that isn't set in stone, but that's the recommendation, to drop down to twice a week. And at that point, you've got no absorption of that estrogen pessary or cream into your body, and it just stays in the pelvic area. So it's much safe and proven to be absolutely fine to use. So for women, I would say at that point is I would normally prescribe 24, and I would give them 14 to use for the first fortnight and 5 weeks of application after. So a good 7 weeks worth, and then say see. And even if they're having painful smears, and that's very typical when your women are approaching the last stages of their screening of smears, I would say use it for a good 6 to 7 weeks beforehand, and that will make a big difference in how comfortable the smear can feel.
So really interesting, really important actually. So there's no real contraindication, is there, for having vaginal estrogen? Is there any woman that you would say absolutely you cannot have it?
No, I can't. I mean, unless there's an unexplained reason or concern for bleeding or any pelvic pathology or cause going on, then I would say no. The only thing that sometimes I see in practice is some women react to the pessary and find it uncomfortable, or changes in how they feel or discharge, in which case they can change to the cream. And it's just worth bearing that in mind. Sometimes they can feel quite defeated because we've built it up into this amazing thing that's going to change them. But, none of this, it's all about being bespoke about treating the individual. So, you know, sometimes you try one thing and it's not perfect. It needs a little longer or it needs a change, and we just got to go with that.
Absolutely, and now we've obviously got a gel as well. There's a ring, the vaginal ring, which is very small, very flexible, that can be used for 3 months. And some people have a combination, don't they? So I certainly often recommend the cream to be used externally if they've got some symptoms there, and then they can still use a pessary. And the pessaries are very low dose, aren't they? They're only 10 micrograms. They used to have a 25 micrograms. So some women use them more than twice a week, and that's safe as well, isn't it?
Yeah, and I think it's really important, just one point to raise in relation to that, because I often have women come back to me in several of my different portfolio roles and say that my GP won't give me any more than 1 10 microgram pessary twice a week. And I think, Louise, you probably see this too. And I think it's really important to not be too dogmatic about this. These are tiny amounts of hormone, and actually the literature does extend its use to 1 alternate day or 2 or 3 times a week. So we can be a little bit, and I think it's good to explore that option before you close that door on it.
Absolutely, and certainly I have some women who don't have any other menopausal symptoms, but I then give them HRT as well because there's no contraindications, and it's a way of having better estrogenization in those tissues, but you can't have too much. And we've also got another pessary now, which is DHEA, which is a precursor for estrogen and testosterone actually in the vagina. So there's always options, and I think again that's really important. And actually some women using the little blue stick with the Vagifem can be incredibly painful to insert. So there's non-hormonal lubricants, moisturizers, and so sometimes it's using those in conjunction as well is really important. So,
absolutely.
Someone has said, how if a woman's using vaginal estrogen, can it affect the male penis if the women are sexually active soon after applying? What do you?
No.
Yeah, I mean, again, it's such a small dose, isn't it? So it's and a lot of women actually put it in the morning if they're going to have sex in the evening because they don't like the idea of it, which I can understand. But again, it's very safe. And someone said, are GPs generally aware that estrogen is useful postpartum, so after birth? And the problem is we don't have training, do we, in the menopause or in hormones, really?
No, and I think we're skilled in postnatal care. So, you know, in the training we do have, we don't get a chance to put into practice. And it's all about exposure and doing something often enough and growing in it. I mean, it's very difficult because general practice was meant to be a generalist field. And it's becoming more and more specialised in every disease, and it's hard to be a specialist in every aspect of the body in primary care. So for many women, I would say, have a look at your practice literature, see who's interested in women's health. If you feel you're that way, you know, or quite often practice lists are open, you can consult any doctor, and they would totally understand that. And I think many clinicians would feel more comfortable to direct you to another colleague within the same practice anyhow. So I think it's really important because you know, the training will catch up, but for the current group of women, I would say find that person.
Yeah, and some of my patients actually have found the right doctor or healthcare professionals. So sometimes it's a practice nurse through Facebook groups or local community groups. They've asked each other, and that's really important as well, because sometimes it might not be the receptionist that knows, you know, or sometimes someone who says they're the women's health expert might not be the best in certain areas. So it's always important to ask other women as well. So Renee, someone has asked again about vaginal estrogen, what about ladies who've had breast cancer, for example, or other cancers? We've said it's safe, but can you just confirm that it's safe, please?
Yeah, exactly. I just had breast cancer written on my piece of paper here. You're absolutely right. We often see patients who we prescribe vaginal estrogens to, and then they come back. They come back to us and say the GP wouldn't prescribe it because I have a family history of breast cancer, or I had breast cancer about 20 years ago, but you know, so I think you can prescribe it even in the presence of breast cancer as long as it's treated and they are cancer free. But what's also important is if you are not sure, you can talk to the breast surgeon, and sometimes I often liaise with the breast surgeon, and then the patient is more confident.
Well, yes, I mean, sadly, we see quite a few women who have been told by their breast surgeons they can never have any form of estrogen, even vaginal estrogen. And it's very hard because they've been told never, ever, ever, and then you're there saying it's absolutely fine and safe. So it's really important. And I've got a really good slide actually that I use for teaching, shows that the absorption of estrogen into the body is the same as a placebo. After day 1, there's a tiny spike, but it's very small. And after that, it's the same as placebo. And actually, the more that vaginal estrogen's used, the thicker the vaginal wall. So it's harder to get into the rest of the body as well, isn't it? So it's very important actually, if someone's on vaginal estrogen, certainly if it's during the perimenopause and menopause, they usually need to stay on it forever. It's different postpartum because once maybe a woman stops breastfeeding, her estrogen might naturally improve, but it won't. You are not going to get that estrogen again. So some doctors only give short courses of vaginal estrogen, but even for women who've had estrogen receptor cancer positive cancer in the past, they can still use it, can't they, the estrogen in the long term. So that's really important, definitely. So also someone was asking about how often to give topical, so vaginal estrogen with HRT, but I've already said in about 1/5 of women, and it's quite safe, isn't it, to use both together. I have a patient who, after her 3rd degree tear 20 years ago, she had an anal sphincter repair immediately after delivery. When I replied that this is routine, she said a colorectal surgeon said to her, this is no longer done. Is she talking about a different procedure? I'm confused. I don't know whether that makes sense to you. So patient, after her 3rd degree tear, had an anal sphincter repair immediately afterwards. She said that this procedure is no longer done.
I wonder whether they mean a repair now, 20 years on.
Maybe.
Anal sphincter injury. So,
Yeah.
so this perhaps must have come up because we have a new treatment, not sacral nerve modulation, which is essentially a treatment where a wire is inserted into the S3 foramen on the sacrum, and it stimulates the sacral plexus. It's a very effective treatment, and sometimes instead of doing a repair of the sphincter, people put in use the sacral nerve modulator. Essentially, you put it in the temporary wire, see if there's improvement in the symptoms, and if there is, they can have a permanent stimulator, which is connected to a battery with very, very good results. And it could be one of the surgeons who practices that.
Right, okay. But it's always good to know there's different procedures available, isn't there? So absolutely. Someone's asked, Ranee, what machine or technique do you use to measure PFM in your one-stop clinic?
Pelvic floor, the strength of fingers. We don't use a machine.
Right, very good. So no excuses then for someone not to do that. Someone has said, this is very interesting, as a GP who has referred women with continence issues postpartum after newborn primary care check, my takeaway impression on catch-up conversations with my patients is that secondary care become defensive about perineal injuries and are dismissive. I've often ended up referring outside the trust that they give birth at. So, I mean, it's very hard, isn't it? I think that's quite a generalisation, isn't it? I think, but there's no harm referring outside the trust, is there? If you want a tertiary referral opinion, then often you do have to. And I think, and women are allowed to ask, aren't they, for referrals elsewhere?
Yeah, so they have to go through their GPs generally, but I'm sure the GPs can. We get a lot of tertiary referrals to our center, and you know, sometimes the women have to fight for it, but they should.
Yeah, absolutely. Sorry, Jo, were you going to say something?
Yeah, I was just going to add to that actually, if you've had a bad experience at the hospital and they're not listening to you and they're very dismissive, a lot of women aren't going to want to go back to that same department and try and fight a second round of battle, trying to get themselves heard. You know, that was certainly my experience at the hospital when my son was born. So yes, I understand where that GP is coming from completely.
Yeah, I think, and it's always, useful sometimes to ask the GP if they know. It's not always necessarily the neighbouring hospital, and it's quite possible to have options. So someone has just commented really about, would it be helpful when seeing a new clinician to have their story written down? And I think, you're nodding there, Jo, but I think it is really important, isn't it?
I actually have what I call a medical CV. So I have so many procedures now that I have a succinct list of what I've had when, that I take to a hospital appointment, because it is so long-winded. You forget over time how much stuff you've had. And so medical CV is the way forward.
I think that's great. I think it's when someone comes with a FSRH file in a 10-minute appointment and puts it in front, you think, oh my goodness, I don't know where to start. But to have somebody who just writes bullets, I'm sure Radhika and Ranee would agree, it's just fantastic, because you can skim read it, you're with the patient, you can talk it through. It just helps so much, and it's helping the doctors to go forward.
Absolutely, agree with you. I mean, I often get people apologising for bringing it, and I'm like, no, it's brilliant. It shows me you care enough to have made some preparation.
Absolutely, yeah. So I know we're conscious of time. There's just a question here about research. I don't know whether, Ranee, you can give us some good news, because I feel we've been quite negative, and I feel it is very negative, but it's positive that we're talking about it. And I'm really grateful to Leigh for actually giving us this time and this platform to be able to discuss something. So I'm hoping going forward things are only going to improve. But is there any sort of research that's going on with incontinence tears, perineal injuries at all?
Yes, so I mentioned the Quality Improvement Program, which is a joint project between the Royal College of Midwives and the Royal College of Obstetricians and Gynaecologists. And in that, we introduced a care bundle. A care bundle is a group of interventions which, when used together, cause improvement. We have to bear in mind that perineal trauma is multifactorial. And therefore, just doing one thing is not going to improve things. You have to do a group of things. And it's for that reason that we developed the care bundle. It was the first project between the Royal College of Midwives and Royal College of Obstetricians Gynaecologists, which is absolutely fantastic, because we cannot deal with this issue unless we work together.
Yeah.
And through that study, we found a reduction in OAC rate. And we used champions in 16 units. But I'm pleased to inform you that we have got further funding, and we are now upscaling that and looking at different ways of actually implementing this care bundle in 20 more units. So altogether 30 units, and we are working on it now. COVID has caused a little bit of delay, but work is ongoing, and we're looking at how to deliver it virtually. So that should be published when we complete it in about 2 years. So yes, it's all positive.
Brilliant, thank you. And I'd just like to end with a very positive comment from someone here to share with you all, to say thank you all for this amazing webinar. I'm so happy to hear so many who embody the beliefs I have now to change the beliefs of others. So, but very, very encouraging words. So thank you very much. And thank you so much to everyone who's listening, and also for the 3 key speakers. And thank you for giving your time. So, and also again, thank you very much to Leigh.
I'm afraid I have to now just take over to say thank you to all of you. Thanks to our audience, but also thank you to our amazing speaker, Louise, Ranee and Radhika, and particularly thank you to Jo. This was incredibly brave of you. I can't imagine the strength that you must have mustered, and to talk to us all, but also to recount your horrific experience over the years. And to share your personal experience, which I'm sure must have helped a lot of people, a lot of women who find themselves in your situation, Jo. Louise has founded a charity, which I must mention, called the Menopause Charity, which aims to set up a website that will be an essential guide to all things menopause, with accurate medical information on the huge range of symptoms and the safest HRT. Now, if you'd like to support the charity in the creation of the website, please go to crowdfunder.co.uk and search for the Menopause Charity. Finally, the MASIC Foundation and Dr. Louise Newson have created a booklet for women who are entering the perimenopause and menopause, and who have experienced birth injury in the form of a 3rd or 4th degree tear leading to incontinence. It's a very useful guide, which we will send to everybody who's registered for this event. The next webinar is on the 21st of October at 4 p.m, when the topic of the discussion will be mental capacity and childbirth, when we hope you will join us. Until then, goodbye.